Hello friends, this is Dr. Madhurima Ganguly, your pediatrics faculty at Global Academy of Medical Sciences, and we have started the pediatric marathon series focusing on INICET, Fmge, NEET or next exams. And since we are going more onto conceptual questions with one-liners with a fusion of conceptual clarity, we will just have the overview of the entire subject in a very short period of time. In the first part, we have already done pediatric rheumatology and all possible questions that can be asked from that sector. So, in today's session, we are going to do the pediatric marathon series 2, that is cardiology. Okay, so let us start. We will be dealing with only the most important points in cardiology. So, first, we are going to do first topic is regarding jugular venous pressure. Okay, JVP is asked in INICET as well as in the past NEET papers. JVP is a very important topic. So first, let us see the waveforms of JVP. So we have got three positive waveforms, that is the A, C, and the V, and two negative deflections, X descent and the Y descent. So we need to know which waveform corresponds to what event in the cardiac cycle, right? First is the A waveform. A waveform is because of contraction of the right atrium. So whenever the atria contracts, some blood is pushed into the internal jugular vein, and that results in a positive deflection, and that is why we get A waveform. So remember A for A. It is the contraction of the right atrium that produces the A wave in jugular venous pressure waveform. Next, coming to C waveform. So what is C waveform suggestive of? It is basically C is closure of the tricuspid valve, right? And the contraction of the right ventricle. So C waveform is basically because of the closure of the tricuspid valve and contraction of the right ventricle. So whenever the tricuspid valve closes and it bulges into the right atrium, the pressure in the right atrium again increases, resulting in a positive deflection in the JVP waveform. Next, coming to the V wave. So V wave is basically because of feeling of right atrium against a closed tricuspid valve. So what you can remember is V for venous feeling, V for V. Like A for contraction of right atrium, C wave is closure of the tricuspid valve. Likewise, you can remember V wave is because of the venous filling of the right atrium that produces the positive deflection of the V waveform. Next, coming to the two descents, the X descent and the Y descent. X descent is relaxation, X for X. So relaxation of the right atrium which results in a drop of pressure, whereas Y descent is because of opening of the tricuspid valve and the blood from the right atrium ultimately begins to fill the ventricles. So summarizing the JVP waveform once more, contraction of the right atrium is A waveform, whereas closure of the tricuspid valve which results in a positive waveform is C wave. V is for venous filling of the right atrium. X descent is relaxation of the right atrium, whereas Y descent is basically filling of the ventricle from the right atrium, which results in a drop of pressure of the right atrium. So, two or three one-liner questions. Closure of the tricuspid valve occurs in which waveform? The answer is C waveform. Opening of the tricuspid valve occurs in Y descent. Contraction of the right atrium occurs in A waveform, whereas feeling of the ventricles occurs in Y descent, right? Contraction of the right ventricle in C waveform. So we should know some minor details regarding the physiology of the JVP. Now coming to some very salient important points regarding the pathology of JVP. So pathological JVP waveforms, first we are going to do absent A waves. So A wave is basically because of contraction of the right atrium, and if there is absent A waves, it is suggestive of atrial fibrillation. So absent A wave is found in atrial fibrillation. So what you're going to get in ECG in a child presenting with atrial fibrillation, that is absent P wave. So in a child with atrial fibrillation, we are going to get absent A waves in JVP and absent P waves in ECG. Now coming to large A waves. Large A waves are going to be found in pulmonary hypertension and pulmonary stenosis. Now coming to cannon A waves, they are also known as giant A waves. So giant A waves and cannon A waves, you can remember just one thing, that is complete heart block or third degree heart block along with some ventricular ectopics or arrhythmias. Coming to large V waves, it is found in tricuspid regurgitation. In a child presenting with tricuspid regurgitation, we say we get the dancing JVP, right? So it is actually because of the large V waveform. Sometimes the C waveform and the V waveform gets joined to form the CV waveform that you find in case of tricuspid regurgitation. So large CV waveform in JVP suggestive of tricuspid regurgitation, and this is known as Lancisi sign. So what is Lancisi sign in JVP? It is nothing but the large CV waveform in case of JVP. So this was a previous year repeat. It is asked in NEETPG 2021 about the Lancisi sign. Large CV waves in tricuspid regurgitation. Now another very important thing, that what is meant by the Kussmaul's sign. What happens during inspiration? JVP falls. But if there is a rise in JVP during inspiration, it is found in constrictive pericarditis and the sign is known as Kussmaul's sign. So we read about the Lancisi sign, we also read about the Kussmaul sign. So let me say a few points regarding constrictive pericarditis. For this, you need to remember one mnemonic. That mnemonic is pay tax. I got this mnemonic from one of the YouTube videos only. So what is pay tax? Pay, that is aggravated Y, or you can remember it as steep Y descent. So steep Y descent is found in constrictive pericarditis. P for P. It's found in constrictive pericarditis. So steep Y descent is found in constrictive pericarditis. In constrictive pericarditis, you're also going to get a rise in JVP, and this rise in JVP is because of the steep Y descent only, and you're also going to get the X descent. Whereas what is tax? That is steep X descent is going to be found in cardiac tamponade. So in cardiac tamponade, you're going to get a steep X descent. In cardiac tamponade, clinically what you're going to get? You're going to get the muffled heart sounds. There is going to be hypotension and elevated GVP. So there is going to be a steep X descent, and remember in cardiac tamponade, there is absent Y descent. So repeating it once more, in cardiac tamponade, we are going to get a steep X descent, absent Y descent, along with a clinical triad of muffled heart sounds, hypotension, elevated JVP, which is known as the Beck's triad, BECK, Beck's triad in case of cardiac tamponade. Okay? And in case of cardiac tamponade, pericardial effusion, in X-ray we get a bottle-shaped heart or a water bottle-shaped heart or a flask-shaped heart. So we did two signs. One is the Lancisi sign, number two is the Kussmaul sign, and some of the very important pathological waveforms in JVP. So hope JVP is clear in a very short manner. Okay. Next we are going to do one very important cause or one important pattern in case of pulse. So we're going to read about pulsus paradoxus. So as the name suggests that there is something paradoxical in this pulse. What happens during inspiration? BP falls. This is a normal event. Why? Because during inspiration, there is increased venous return to the right side of the heart. Definitely, there is a septal bulging towards the left. Because of that, the left ventricle, the stroke volume from the left ventricle decreases and there is a hypotension. So, usually, there is a fall in BP during inspiration, which is a normal event. But if there is a fall in BP more than 10 millimeters of mercury, then we call it as pulsus paradoxus. That is not physiological, that is pathological because of some underlying causes in the heart which results in much more fall in BP than expected during inspiration. So, fall in BP more than 10 millimeter of mercury is what is known as pulsus paradoxus. And here we have the causes of pulsus paradoxus. And again, this is a very, very important question, both from your physiology, medicine, as well as pediatrics points of view in your examination. So, pulsus paradoxus causes number one is cardiac tamponade. Number two, constrictive pericarditis. So, what happens in constrictive pericarditis? The heart is so stiff, we find that there is much more, there is less stroke volume. Okay, severe acute asthma, some obstructive cause, massive pulmonary embolism, and tension pneumothorax. So you have to remember these five causes of pulsus paradoxus. Another cause you can remember is the superior vena cava obstruction syndrome, SVOC. Okay, and another pulse waveform which I would like you to understand is pulsus alternans. It is nothing but an alternate of high and low volume pulse, and it is characteristic of left ventricular failure. Okay, so it is a feature of high and low volume pulse. So this is what waveform you are going to get in case of pulsus alternans. So we did pulsus paradoxus and pulsus alternans. So from the physiology point of cardiology, we did the jugular venous pressure and two very important pulse characteristics of abnormal pulse. Okay, so now we are going to go in the pathology process, and the first thing we are going to read a very, very important criteria that is known as the NADA's criteria. And in this NADA's criteria, first question, NADA's criteria is to diagnose congenital heart disease. So what does NADA's criteria tells you? It tells me about congenital heart disease. So it has got a major criteria and minor criteria. How we are going to diagnose? We need to have at least two major criteria or one major plus two minor criteria. So this is for the diagnosis of congenital heart disease. And we are going to have one major plus two minor criteria or two major criteria. So let us read first the major criteria. Systolic murmur grade 3 or more. Remember, this grade 3 or more is important because any systolic murmur less than grade 3 falls in the minor criteria. Any diastolic murmur falls in the major criteria. Cyanosis and heart failure are two other parameters which belong to the major criteria, whereas those which belong in the minor criteria include abnormal second heart sound, abnormal ECG, abnormal chest x-ray, and abnormal blood pressure. So we have the major and the minor. You can get confused in the systolic murmur. Systolic murmur is present in both major and minor. Remember, systolic murmur grade 3 or more falls in the major criteria, whereas less than grade 3 falls in the minor criteria. Okay, so this is a very important chart. It is regarding the cyanotic congenital heart diseases. So congenital heart disease with cyanosis, we are going to tell as cyanotic congenital heart disease. We can classify them into two parts based on the pulmonary blood flow. Increased pulmonary blood flow and decreased pulmonary blood flow. Now let me first tell about the ones that is the cyanotic congenital heart disease with increased pulmonary blood flow. So CCHD with increased pulmonary blood flow. First understand that what is the physiology? They are cyanotic congenital heart disease with an increased pulmonary blood flow. Now, what is going to be the presentation clinically? These children are going to present with recurrent infections. They are going to get admitted in the hospital numerous times because of pneumonia, and they're also going to have failure to thrive. So, clinically, we are going to get recurrent infections, sepsis, pneumonia. And what you're going to get radiologically. So, radiologically, we are going to get increased bronchovascular markings, which we call as pulmonary plethora in chest X-ray. So, what do we call it? We call as pulmonary plethora. Now, we need to remember all the causes of pulmonary plethora because this is very important MCQ that is asked in your exams. Okay, the first is TGA, transposition of the great vessels. Number 2, total anomalous pulmonary venous connection. Persistent truncus arteriosus, single atrium, single ventricle. So this 5 causes you should know by heart, and this is a last moment table which you must revise. There are definitely causes that why in TGA we get increased pulmonary blood flow or why in single atrium there is increased pulmonary blood flow. But I'm not going into the details of it since this is a marathon series. For knowing the details, you must follow my regular classes. But at least for your exams and for the last moment preparation, you should know each and every point or each and every congenital heart disease which falls under the category of increased pulmonary blood flow. Okay. Now coming to the next sector, that is the cyanotic congenital heart disease with decreased pulmonary blood flow. So what are the CCHDs with decreased pulmonary blood flow? So again, decreased pulmonary blood flow will mainly present with cyanosis. So what will be the clinical manifestation? The clinical manifestation will be mainly of cyanosis, and there is going to be failure to thrive, and in the radiologically we are going to get something which is known as pulmonary oligemia. So we'll get a more lucent or black lung fields, right? There is going to be decreased bronchovascular markings. And let us remember the causes because cyanotic congenital heart disease with decreased pulmonary blood flow is more important for your exam purpose. So cyanotic congenital heart disease with decreased pulmonary blood flow, the first thing we have is Tetralogy of Fallot or TOF. Number 2 is tricuspid atresia, pulmonary atresia, Ebstein's anomaly, hypoplastic right heart syndrome. Now, let me tell you in the cyanotic congenital heart disease, which cyanotic congenital heart disease will present with left axis deviation in ECG or will present with left heart dilatation or hypertrophy. So, there is only one congenital heart disease which presents with this, that is nothing but the tricuspid atresia. So, tricuspid atresia, we are going to get left axis deviation, left ventricular hypertrophy. Okay, and remember in tricuspid atresia, we usually go for a surgery that is known as the Fontane's operation. So, Fontane's surgery is done for, the answer is tricuspid atresia. And there is another one-liner question regarding this Fontaine surgery. What is the most common cause of chylothorax? Most common cause of chylothorax is trauma. So let me write over here. So most common cause of chylothorax, the answer is trauma. And what trauma? It is post-operative. And which operation I am talking about? It is post-Fontaine surgery. And Fontaine surgery is used for tricuspid atresia. So most common cause of chylothorax is trauma. It is post-operative and it is Fontaine's. Chylothorax can have other causes also, like it can have a thoracic duct injury due to any other cause, and it can be because of tuberculosis, malignancy, etc. But the most common cause of chylothorax is trauma. right? So we did the tricuspid atresia. The tricuspid atresia will have left axis deviation, very important. Cyanotic congenital heart disease with left axis deviation, or cyanotic congenital heart disease presence in ECG as left axis deviation and left heart dilatation. The answer is tricuspid atresia. And remember, tricuspid atresia is a duct dependent condition. So we need to start with PGE1 analog, that is alprostadil. And later on, we need to go for the definitive surgery, Fontan surgery. Okay. So let us quickly see some images that is related to congenital heart disease. So as you see over here, we have two images. One is the chest X-ray and the other is the echocardiography. So first see the echocardiography over here. So can you see that the right atrium is enlarged and rather the tricuspid valve, it is actually sagging below, and the right ventricle is small. So since the right atrium, because of the leaky tricuspid valve, we can have tricuspid regurgitation in this condition, and it is called ARV, that is nothing but atrialization of the right ventricle. Okay, so the right atrium is basically atrialized. Atrialization of the right ventricle. Right ventricle is small, hypoplastic. Why? Because it is atrialized. So, which congenital heart disease presents with atrialization of the right ventricle? Which congenital heart disease presents with leaky tricuspid valve? Which congenital heart disease presents with cyanosis, decreased pulmonary blood flow, as well as there is going to be tricuspid regurgitation. So all the answers are same, that we are dealing with something which is known as Ebstein's anomaly. Now let us go back to the chest X-ray and see. So this is nothing but a box-shaped heart. Okay. So remember, this is a box-shaped heart. And this box-shaped heart we are going to get in a condition which is known as Ebstein's anomaly. Okay. So this is a cyanotic congenital heart disease. This X-ray image and the echocardiographic image is suggestive of Ebstein's anomaly. So in case of Ebstein's anomaly, first of all, you know that it is a duct dependent condition. So if this is a duct dependent condition, we need to start with PGE1 analog and then we'll do the definitive surgery, right? Number two, there will be a history of exposure to lithium in the pregnancy period. Okay, so exposure to lithium in mother or maternal exposure to lithium. There is atrialization of right ventricle ECG is suggestive of Himalayan P waves, that is nothing but the tall P waves. And apart from Himalayan P waves, we are also going to get something which is known as WPW syndrome is associated with Ebstein's anomaly. So there can be cardiac conduction defects as well. In the chest X-ray, we are going to get a box-shaped heart. So these are the features of Ebstein anomaly. So what clinical question can you expect? A mother is taking a drug during pregnancy for bipolar disorder or mood disorder or manic depressive psychosis, or a mother has a history of uh, taking an antipsychotic drug or a mood stabilizer. What congenital heart disease can you expect in the baby? The answer will be Ebstein's anomaly. So lithium and Ebstein's anomaly. WPW syndrome is associated with which cyanotic congenital heart disease? Answer is again Ebstein's anomaly. What do you get in WPW syndrome? Wolff-Parkinson-White syndrome. You're going to get a short PR interval, tachycardia, narrow QRS complexes, and we are going to get a delta wave. So in WPW syndrome, you're going to get short PR interval, narrow QRS, and we are also going to get a delta wave. slurring of the initial part of the Q wave is what we are going to find in WPW syndrome, and tall P waves. Okay, these are known as Himalayan P waves. These is also a characteristic of what? Ebstein's anomaly. In the chest X-ray, we are going to get a box-shaped heart. So these are the very, very important one-liners related to Ebstein's anomaly. Now coming to the next image, this image is suggestive of egg on side appearance. An egg on side appearance. Can you appreciate the egg over here? And this is suggestive of transposition of the great arteries or the great vessels. So TGA, transposition of the great vessels with present with egg on side appearance. Another question very similar, radiology question, egg in cup appearance is suggestive of. So egg in cup appearance in chest X-ray is suggestive of constrictive pericarditis. So we already read in JVP about the Kushmal sign that we are going to get in constrictive pericarditis. Now we also read one radiological feature associated with constrictive pericarditis, that is egg in cup appearance. Okay. Now let me tell you what is transposition of the great vessels. Right, as the name suggests, the great vessels are transposed. So what you need to, there can be of two types. One is TGA with intact ventricular septum. If we are getting a TGA with intact ventricular septum, it is a duct dependent condition. It is emergency. We need to start PGE1 analog as soon as possible, and we need to send the baby for an emergency surgery. And otherwise, if you are going to have TGA with VSD and all, it will also present with cyanosis, but we have to go for surgery, the definitive surgery. We can either have to go for arterial switch, that is known as the Jatin's arterial switch repair. Jatin's arterial switch repair, but that is not an emergency procedure. Now, one thing more, it is the most specific heart disease that you are going to get in an infant of diabetic mother. So, most specific heart disease found in infant of diabetic mother is nothing but transposition of great vessels. Even TGA is also the most common heart disease that you get if the mother has phenylketonuria. So if a mother is having phenylketonuria, maternal phenylketonuria, what congenital heart disease you can expect in the baby? The answer will be transposition of the great vessels. Now next, can you just appreciate the figure of 8? So this is nothing but the figure of 8 appearance. It has another name also, that is the snowman appearance. And this is suggestive of supracardiac total anomalous pulmonary venous connection. Now, since I'm doing TAPVC, I would like you to understand few points. One of the very important questions that comes from TAPVC is that PGE1 has no role in TAPVC, right? There is no point in giving PGE1. So, PGE1 analog has no role in TAPVC. So, you need to take the baby for surgery. It is the total anomalous pulmonary venous connection. Normally, the pulmonary veins open in the left side of the heart or the left atrium. But here it is a total anomaly. That is, instead of opening into the left side of the heart, the veins are going to open in the right side of the heart. Okay, so either they are going to open directly or through indirectly. According to that, we have some classification of total anomalous pulmonary venous connection. Another MCQ point which is very important and was doubly repeated in INICET. Okay, once in AIMS, and when INICET came into place, it was also repeated in INICET. That is saturation in all the chambers of the heart, or SpO2 in all the chambers of the heart is equal in TAPVC. This is a direct line taken from Nelson. So SpO2 is equal in all the chambers of the heart in case of total anomalous pulmonary venous connection. Now, what are the different types of TAPVC that we have? Number one is the supracardiac. Number two is the cardiac. Number three is the infracardiac. Now, from clinical point of view, we usually divide total anomalous pulmonary venous connection into two broad types. One is obstructive variety, other is non-obstructive variety. Obstructive variety presents early in the neonatal age because it will present with severe cyanosis and we need to go for an emergency surgery. Whereas non-obstructive variety can feature a little later, and the main presentation of non-obstructive variety is going to be heart failure. Now remember, 90% cases of infracardiac type of total anomalous pulmonary venous connection is obstructive. Whereas usually supracardiac and some of cardiac is non-obstructive. Supracardiac 30% can be obstructive, the rest are non-obstructive. Okay. So what happens in supracardiac? It means above the level of heart. That is, the pulmonary veins are going to open either in the innominate vein. Innominate vein is brachiocephalic vein, or in the superior vena cava. So the pulmonary veins open in the SVC or in the innominate vein. Whereas what happens in the cardiac one? In the cardiac one, they are going to open either directly in the right heart, that is right atrium, or they are going to open in the coronary sinus. Right? What will happen in case of infracardiac variety? They are going to open in the hepatic vein, portal vein, or in the inferior vena cava. So, hepatic vein or IVC. So, supracardiac, cardiac, and infracardiac. And this picture is suggestive of supracardiac total anomalous pulmonary venous connection. And perhaps the most important image of the day, that is, this is, you all know this. This is nothing but the boot-shaped heart. And the better name of boot-shaped heart is Cohen-Sabor. Tetralogy of fallot. Now, can you appreciate, first look at the lung field. Are they appearing lucent or black? There is less bronchofascicular markings. So this is known as pulmonary oligemia. Now look at the apex. The right ventricular apex is turned upwards. There is a concavity up. So this is a shaping like a boot. So that is why it is known as boot-shaped heart. Now, few questions that we are going to read from top, which are commonly repeated. Number one, what are the four components of TOF? Tetralogy of fallot में tetralogy क्या है? Number one is ventricular septal defect. So it is a large non-restrictive VSD. Now let me make you understand two very important points regarding this non-restrictive ventricular septal defect, which is large and perimembranous. Normally VSD produces a pan-systolic murmur. So what about the murmur of VSD in case of TOF? You're not going to hear any murmur. Why? Because of the large perimembranous ventricular septal defect, there is equalization of pressure in both the chambers. As a result, there is no flow, no turbulence, and we are not going to get any shunt murmur. Right? Number two is we are going to get right ventricular outflow tract obstruction. And this is the most important component of TOF. So, second one-liner. What is the most important component of TOF? The answer will be right ventricular outflow tract obstruction. So right ventricular outflow tract obstruction, what form will it happen? Then one, it will be infundibular stenosis. Infundibular stenosis. We can have pulmonary stenosis, pulmonary atresia, etc. But the most common form of right ventricular outflow tract obstruction will be infundibular stenosis. Number 3, we are going to have right ventricular hypertrophy. And number 4 is overriding of aorta. And remember, it is less than 50%, because if it is more than 50%, then it will be DORV, double outlet right ventricle. Okay, so RV thorough with the 4 components of TOF, that is the ventricular septal defect, right ventricular outflow tract obstruction, right ventricular hypertrophy, and overriding of aorta less than 50%. Now, what is pentalogy of fallot? In case of pentalogy of fallot, we are going to have an additional atrial septal defect. Next, of course, it is a condition where we are going to have right to left shunt, and there is decreased pulmonary blood flow, so there is going to be pulmonary oligemia. It will present with cyanosis. Now, 2 important questions. Can TOF be present in any syndrome? The answer is yes. Syndromic TOF, you are going to get something which is known as the DiGeorge syndrome. I'll explain DiGeorge syndrome later in this cardiology module only. So, in DiGeorge syndrome, we are going to get TOF. So, we usually remember DiGeorge syndrome by the most important mnemonic, that is the catch-22 mnemonic, right? Chromosome 22q11 microdeletion being involved with TBX1 transcription factor being involved in DiGeorge syndrome. So, TOF associated with which syndrome? The answer is DiGeorge syndrome. And which electrolyte abnormality that we find in case of DiGeorge syndrome? The answer is hypocalcemia. So, we get hypocalcemia in case of TOF. So, if you get a child with TOF with dysmorphic facies and you are thinking that I am dealing with a syndromic baby, please do a venous blood gas analysis and monitor calcium level, and you will find that there is hypocalcemia. So, DiGeorge syndrome and hypocalcemia can be associated in a child with TOF. Next, TOF is also associated with right-sided aortic arch. So, right-sided aortic arch is found in case of TOF. In how much percentage we are going to get the right-sided aortic arch? Remember, right-sided aortic arch is found in 20% cases in case of tetralogy of fallot and 30% case in case of persistent truncus arteriosus. So, in case of persistent truncus arteriosus, we are going to get 30%, whereas in case of TOF, we are going to get 20%. Understood? Now, if I ask you most common heart disease that you find in a baby with DiGeorge syndrome, the answer is not going to be TOF, it is going to be interrupted aortic arch syndrome. Okay? So, TOF कौन सा syndrome में ज़्यादा associated होता है? The answer is DiGeorge syndrome, but it is not the other way round. Now, what you will get clinically? Usually, TOF babies do not present with heart failure, but if there is hyperdynamic circulation, like we are going to have beriberi, anemia, or infective endocarditis, systemic hypertension, we can get heart failure in a baby with tetralogy of fallot. So, what will be the clinical finding? Already I told you there is going to be no shunt murmur because it is a large VSD, and there is going to be no heart failure. So, you're not going to get any feature of heart failure. Why? Because all the blood is actually being channelized into the aorta. So that is why we are not going to get any failure in this baby normally, unless and until we are going to have infective endocarditis or child with hyperdynamic circulation. Number 3, are we going to get any murmur in TOF? The answer is yes. Why are you going to get any murmur in TOF? Because of right ventricular outflow tract obstruction, infundibular or pulmonary stenosis. That will produce a murmur in case of TOF. So what murmur will it be? It is going to be a ejection systolic murmur. So we are going to get a ejection systolic murmur in case of TOF. and we are going to get a single second heart sound. So why single second heart sound in case of TOF? Because second heart sound is comprised of two components, A2, P2, aortic valve and pulmonary valve. But here the pulmonary valve is either atratic or stenotic. So we are only going to hear the sound of the aortic valve closure, not the pulmonary valve. So we are going to get a single second heart sound. Now let me tell you two very important points regarding this TOF murmur, right? That is the ejection systolic murmur. So as the obstruction increases, we are going to get more turbulence and the murmur intensity in case of TOF will increase. However, if there is a very severe obstruction, when there is no flow, there is going to be complete absence of the murmur. Okay, let me give you an analogy of a river, right? So you have seen river in hills also, and you have seen some river, the Ganges, in the plains also. Do you hear any sound in sound of the river in the plains? No, it is white and there is no sound because there is no turbulence, but you hear a sound in case of hills. In the those rivers in the hills, you get a sound because of the turbulent flow. And since there is, so that means sound only you hear when there is a turbulence, right? So turbulence means there is more velocity of flow of the river. So what happens? So whenever the blood has to flow through a mild to moderate obstruction, there is turbulence. So the intensity increases. There you get a murmur. But what happens when there is a severe obstruction? Suppose पहाड़ों का जो नदी है उसमें ही हुआ कि those river in the hills, almost all deposition by stones or deposition by boulders, and the flow of the river is obstructed. So when river flow of the water of the river is obstructed, there is no flow, there is no murmur. So remember, since the murmur intensity is directly proportional to the turbulence, but in severe obstruction a paradoxical response occurs in case of TOF where you may not hear any murmur. So suppose you are seeing a child with TOF and you know that there is a ejection systolic murmur, there is a single heart sound, and there is a RV type of apex. So you know it clinically. But what happens one day, you find that there is worsening of cyanosis and there is no murmur. So no murmur in TOF is very ominous because no murmur in TOF means only two things. One is severe obstruction, and number two is that there is a cyanotic spell. So what is the triad that you get in cyanotic spell? What is cyanotic spell? There is the baby is going to present with worsening of cyanosis. There is going to be increased respiration. The rate and depth of respiration is going to increase. Along with that, there is going to be absence of a previously heard murmur. So understood the triad which I am trying to explain. Number one, there is worsening of cyanosis. Number two, there is absence of a previously heard murmur. And number three, there is increased rate and depth of respiration. You know what happens? Whenever there is a right ventricular outflow tract spasm, right? So what happens is that the respiratory tract is respiratory center in the brainstem, in the medulla, is stimulated by, there is usually hypoxia, spasm of the RVOT, there is hypoxia, there is acidosis, and there is hypercarpia. All these things stimulate the brainstem respiratory center. So there is going to be rate and depth of respiration is going to be increased. You're going to get tachypnea and hyperapnea, and there is going to be increased venous return to the right side of the heart. And again, this is going to result in more RVOT spasm, and this as a vicious cycle will go on. Usually what happens is that the baby is going to prefer a knee chest position or a squatting position or scissoring position, that is known as the Krishna position, because in all these three, the RVOT spasm will decrease, the shunt flow of blood, the right to left shunt is going to decrease. Okay, so whenever we get a baby of cyanotic spell, usually we first give oxygen, we put the baby in the mother's lap in a squatting position or a knee chest position, and then we sedate the child. We give morphine or ketamine to sedate the child, and after that we usually try to correct each and every step of the pathophysiology. So there is metabolic acidosis, so we give sodium bicarb to combat that. And there is increased retin depth of respiration, so we give oxygen, and we try to decrease the sympathetic drive. That is why we give sedate the patient, and we can give propranolol. Okay, so propranolol decreases the RVOT spasm. It also results in bradycardia, so it decreases the spasm. Okay, and we can also give phenylephrine or methoxamine. And if all these things fail, we need to put the baby in the ventilator. So for your questions, at least you should remember knee chest position or squatting helps in TOF. Only in TOF? No, also in TOF physiology. In those congenital heart disease where we are going to get right ventricular outflow tract obstruction, those conditions are known as TOF physiology because these conditions mimic the basic disorder, that is TOF, right? So if you are going to get DORV plus VSD plus PS, TGA plus VSD plus PS, so all these falls in the category of TOF physiology. Okay, so in TOF and TOF physiology, we are going to get something which is known as the cyanotic spell. What you should remember, cyanotic spell triad kya hai? Worsening of sinuses, absence of murmur, increased respiration, right? And cyanotic spell, why? Because of right ventricular outflow tract spasm. वो क्या करता है? ब्रेन स्टेम जो रेस्पिरेटरी सेंटर है उसको स्टिमुलेट करते हैं. What are the stimulating factors? Decreased pH, decreased PO2, and increased PCO2. That is hypoxia, hypercarbia, and acidosis. So what is the drug of choice to prevent or as a prophylaxis for cyanotic spell? The answer will be propranolol. Now, another question from TOF physiology is that suppose you get a baby with TOF and you find that there is an acute CNS event. So, TOF baby with acute CNS event. So, it can be in the form of seizures, it can be a focal neurological deficit, or it can be in the form of fever with seizures. So, what are the possibilities in a baby with TOF with CNS event? It can be a cortical thrombosis. Why does thrombosis occur? Because in TOF there is polycythemia, right? It results in hyperviscosity, and hyperviscosity polycythemia will result in formation of thrombus, and there is a chance of paradoxical embolism. And the third one is brain abscess. Now, if I'm talking about brain abscess, one thing very commonly asked that in TOF, in brain abscess, which lobe is affected? So, which lobe is affected in a TOF with brain abscess? The answer will be parietal lobe. So TOF, if I'm getting a baby with TOF in the neonatal period with pulmonary atresia, it is a drug dependent condition. We need to start with alprostadil as soon as possible, and then we have to go for the definitive procedure. As a result, in TOF, what we do is that we go for some palliative shunt surgery, or we can go for and the definitive surgery later, like repairing of the VSD and repairing of RV. We can do some palliative surgeries like right ventricular stenting. If there is a PDA also, we can go for a PDA stenting as well. So let us discuss. So in brief, this is about the various one-liners that can be asked from TOF. Let me just summarize it, and then we'll go for the various palliative shunts which are available for TOF. First is the four components of TOF: VSD, right ventricular outflow tract obstruction, right ventricular hypertrophy, and overriding of aorta. Pathology includes ASD with syndrome associated DiGeorge, right-sided aortic arch found in 20% of the cases. Do you get a shunt murmur in TOF? Answer is no. Single second heart sound found in TOF? True statement. Ejection systolic murmur in TOF is basically because of pulmonary stenosis. Will the murmur increase if there is increase in obstruction? The answer is yes. If there is a severe obstruction, there is going to be no murmur. So if you are getting no murmur in a TOF baby where previously murmur was hard, the answer will be severe obstruction or there is a cyanotic spell. So what are the 3 points in cyanotic spell? Worsening of cyanosis, increase in respiration, and there is going to be absence of a previously heard murmur. What is the drug of choice to prevent cyanotic spell? The answer is propranolol beta blocker, non-selective beta blocker. TOF with CNS event, what are the possibilities? Paradoxical embolism, cortical dural thrombosis, and brain abscess. Which lobe is affected? Parietal lobe is affected. So TOF is a condition with cyanotic congenital heart disease with decreased pulmonary blood flow. So what you're going to get in X-ray, you're going to get a concave right ventricular apex with pulmonary oligemia that is known as the boot-shaped heart or the quoad in savo. So we can have various complications of TOF like infective endocarditis. Number 2 is paradoxical embolism, hyperviscosity, polycythemia, growth failure, etc. can happen. Okay. Now we are going to do this thing, this shunt. So what are the types of shunt that is available in case of TOF? First is the Blalock Taussig shunt, also which we know, we call it in a short form wise BT shunt. Okay. So BT shunt, what you can remember from BT shunt is that it the connecting arteries, pulmonary artery to subclavian artery. So SA is nothing but subclavian artery. Okay, so what is modified BT shunt? Modified BT shunt, we go it by Gore-Tex graft. What is pot shunt? It is between the left pulmonary artery and the descending aorta. So DA stands for descending aorta. Next is the Waterston shunt. Waterston shunt is between the right pulmonary artery and the ascending aorta. Now you can get confused between the pot shunt and the Waterston shunt. Remember in Waterston shunt we have the word A and A for A, that is A for ascending aorta. Pot shunt descending aorta, Waterston shunt is ascending aorta. And the most commonly is the BT shunt. So suppose in a TOF baby BT shunt is placed. So what will you get clinically? You're going to get clinically a continuous murmur. So if you get a continuous murmur in a baby with BT shunt, then we are going to understand that the shunt is functioning properly. But in a baby with BT shunt, if there is a gradual onset cyanosis, then we can think about shunt insufficiency. And if there is a sudden onset cyanosis in a baby with postoperative BT shunt in situ, we can think about shunt block. Okay. And that is very emergency shunt block. We need to either go for thrombolysis or some emergency procedures. Now see this image. So this is a palliative shunt technique which was done between these two arteries, as you can see over here. So can you tell me which shunt surgery has been performed here? It is between, as you can see, it is the right pulmonary artery over here and the right subclavian artery, and this is the shunt surgery that is formed. So this is nothing but it is the BT shunt or the Blalock Taussig shunt. So the first question, Blalock Taussig shunt is done for. The answer will be TOF. Modified BT shunt is the procedure of choice now. What are the other procedures that you know of? The answer will be pot shunt and the Waterston shunt. So that finishes in a very short manner regarding the various one-liner questions that can be asked from Tetralogy of fallot. Next image. So can you see this sword over here? So this is nothing but the sword sign. So appreciate with this diagram. So hopefully you can, in this image, you can see the sword, and here the sword is not there. So you have to understand. So this is shaped, this image pattern is shaped like a sword. So this is known as the sword sign, and achieve bath regarding a better name for a sword is known as the scimitar. So we call it as the scimitar sign. And this is found in a condition which is known as PAPVR, that is partial anomalous pulmonary venous connection. Partial anomalous pulmonary venous connection. Okay. So this is nothing but the scimitar sign. So we are going to go in the next topic in cardiology, that is the acute rheumatic fever. So acute rheumatic fever, we are going to read the revised Duckett-Jones criteria. But before reading the revised Duckett-Jones criteria, we need to know what is meant by a low risk population and moderate to high risk population. So first is the low risk population. The definition of low risk population is acute rheumatic fever incidence is less than equal to 2 per 1 lakh school aged children, or rheumatic heart disease prevalence is less than equal to 1 per 1,000 population in all ages. This is a very, very important. See, whenever I'm using the word incidence, that is only new cases, it is school going children. Whereas whenever, and also it is acute rheumatic fever. Whereas whenever I'm talking about the word prevalence, old plus new, it is in all ages, it is rheumatic heart disease. So please note this when you see in the exam which option you're marking. Because in ARF, incidence will be less than equal to 2 per 1 lakh, whereas rheumatic heart disease prevalence will be less than equal to 1 per 1,000. India falls in moderate to high risk population. So now we are going to read about the revised Duckett-Jones criteria. And in the revised Duckett-Jones criteria, first we'll read about the major criteria. So major criteria of acute rheumatic fever. And in the major criteria of acute rheumatic fever is different for low risk population and moderate to high risk population. The first thing is carditis. Remember, it is a pan-carditis because it can involve any layer of the heart. It can involve the endocardium, it can involve the myocardium as well as the pericardium, right? If the pericardium is involved, you can have pericarditis, pericardial rub. You're going to have chest pain. If it is a myocardium, there can be myocardial dysfunction, there can be heart failure. Whereas endocardial, it is involvement of the valves. Okay, the aortic valve is most commonly involved. So this carditis can be clinical. That is, you can get a baby with heart failure, a child with a pericardial rub or chest pain, all this, and a valvular involvement and murmurs from valvular involvement, or you can get a subclinical carditis. So it can be either a clinical carditis or subclinical carditis. So remember, subclinical carditis is now a criteria in acute rheumatic fever. So how are you going to diagnose subclinical carditis in acute rheumatic fever? It is by echocardiography. Okay. Coming to the most important or the most common criteria that we get in India, it is the involvement of the joint. That is arthritis. So you already know the difference between arthralgia and arthritis. I have discussed in my rheumatology module. Just recollecting it once more. Arthralgia means pain in the joint, whereas arthritis is you're going to get all the signs of inflammation. It will be a tender joint, red joint with loss of function, and there is going to be swelling. So polyarthritis in the low risk, whereas in the moderate to high risk, we can have polyarthritis, monoarthritis, or polyarthralgia. Very, very important point, because I'll soon be doing the minor criteria and you'll get confused. And the examiners know which sector you're going to get confused, and they frame questions from that only. And remember, this arthritis is migratory or fleeting in nature. So the characteristic of this is migratory or fleeting in nature. What is meant by migratory or fleeting pattern of arthritis? It means that suppose my right knee joint is involved today. After 3 days, the child will come to me with involvement of the left joint, knee joint, and resolution of the pain in the right knee joint. So it as if the pain migrates from right knee joint to left knee joint and to subsequent other joints. And there is an involvement of the large joint only. So definitely it is asymmetric, and it has got a dramatic response to salicylates or aspirin. So whenever you put the child on aspirin, the pain subsides. And this is very important because this helps you to differentiate from arthritis due to other causes. Next is chorea. Chorea is an extrapyramidal movement, and chorea in acute rheumatic fever has got two names. One, it is known as the Sydenham's chorea. Also, it is known as the St. Vitus's dance. And remember, it is a very late manifestation of acute rheumatic fever. And again, this is an exception to the Duckett-Jones criteria. So there are three exceptions to the Duckett-Jones criteria, because if you have those three criteria, at least you should remember two. That is, one is chorea and number two is indolent carditis. So if you're having these two things, then you can escape this criteria which I'll be talking about. So chorea is an exception to the rule of Duckett-Jones criteria. And we must remember two more one-liners related to chorea. That is, what is the drug of choice of chorea? The answer will be phenobarbital. And what is the drug of choice in case of refractory chorea? This was asked in NEET multiple times. The answer will be IVIG or plasmapheresis. Next, to skin manifestation, erythema marginatum and subcutaneous nodules. Remember, from subcutaneous nodules has got a very strong association with carditis. So strong association with carditis. So suppose you are having a child with subcutaneous nodules, you can jolly well say without even echocardiography that you're going to get carditis. So this is all about the major criteria in case of acute rheumatic fever. Now coming to the minor criteria. Again, it is divided into the low risk population and moderate to high risk population. First is C. Polyarthralgia belongs to the low risk population and monoarthralgia in the moderate to high risk population. Now go back again to the previous one. See, polyarthralgia is a major criteria in moderate to high risk population. However, this polyarthralgia is a minor criteria in low risk population. So don't forget this, that polyarthralgia major criteria में included है in moderate to high risk population, whereas polyarthralgia minor criteria में included है in low risk population. Okay. Next is fever. Fever more than 38 degrees Celsius in moderate to high risk, whereas more than 38.5 degrees Celsius in low risk. ESR and CRP are raised. ESR more than 60 millimeter in the first hour, or CRP more than 3. CRP more than 3 in both the groups, whereas ESR more than 60 in low risk and more than 30 in moderate to high risk. In moderate to high risk, we always have a lower cutoff, and usually you will be asked more about the moderate to high risk only because we are living in India, not in the Western world. And the last is prolonged PR interval in ECG. So what finding you are going to get in acute rheumatic fever in ECG? That is the prolonged PR interval. Okay. So two inflammatory markers, ESR, CRP, ECG changes, clinical factor, fever, and the joint involvement. All these belongs to the minor criteria of acute rheumatic fever. Now coming to the essential criteria. So this is the essential criteria. Which is suggestive of evidence of recent streptococcal infection. Because what you should remember from here, मेजर क्राइटेरिया माइनर क्राइटेरिया होना है, बट उसके साथ एसेंशियल क्राइटेरिया इज एसेंशियल फॉर डायग्नोसिस ऑफ acute rheumatic fever. What are the essential criteria we have? Positive throat swab culture, increased in anti-streptolysin O titer, more than 250 TOD units, and positive rapid antigen test. Okay. This more than 250 TOD units is only in case of children. So I'll not go in the detail of how do you diagnose recurrent attacks of acute rheumatic fever. How do you diagnose it? What is the echo criteria? I'm not going to that. And how do you manage acute rheumatic fever? I'll just do another table on secondary prophylaxis, right? And duration of secondary prophylaxis duration in case of acute rheumatic fever, because this is a very important question. First is rheumatic fever with no carditis. That means there is no carditis, echo maybe there is no cardiac involvement. Then we are going to give secondary prophylaxis for 5 years or 21 years, whichever is longer. Very important. Suppose I get a child at 15 years of age and there is rheumatic fever with no carditis, then I'm going to give secondary prophylaxis. 15 plus 5 hota hai 20. So whether I'll give it for 20 or 21, the answer will be 21 years, whichever is longer. Next is rheumatic fever with carditis with no valve involvement. So carditis is there, but endocardium involvement is not there. No valvular involvement is there. So it is 10 years or 21 years, whichever is longer. So पहला वाला था 521, whichever is longer. Next is 1021, whichever is longer. The last one, remember, it's rheumatic fever with valvular involvement. So we call it as severe disease, also known as post-intervention patients or persistent valvular disease. This is given in IAP textbook. Persistent valvular disease. It is 10 years or 40 years or lifelong. So understood, 5 year 21 years, 10 year 21 years, 10 year 40 years or lifelong is what is the treatment of secondary prophylaxis duration in acute rheumatic fever. Next, we are going to read about infective endocarditis and we are going to read the Duke's criteria for infective endocarditis. So Duke's criteria has got two parts. One is the major criteria and the minor criteria. In this rapid revision, we are going to read only about the major criteria. So we are going to do infective endocarditis Duke's criteria. So in the major criteria, we have two major criteria. One is the positive blood culture and number two is the echocardiographic criteria. So first is the positive blood culture. So it is the typical microorganisms grown in two separate blood cultures. So what are the typical microorganisms that are positive in case of infective endocarditis? Streptococcus viridans, Staphylococcal aureus, Streptococcus galolyticus and Hackett group. Remember, Hackett group is a fastidious organism. Or we can have the community acquired enterococci in absence of a primary foci. So let me tell you, the most common cause of infective endocarditis is Staphylococcal aureus. And the most common organism in IV drug abusers, it's again Staphylococcal aureus. The right-sided valve is more commonly involved as compared to the left-sided valve. Okay, and enterococci is more common after genitourinary or gastrointestinal tract procedures. Okay, so and the most common organism in prosthetic valve overall is the coagulous negative staph. So these are the few one-liners regarding microbiology which you should be aware of. So most common cause is Staph aureus. And Staph aureus again is the most common cause in overall as well as in IV drug abusers. And in IV drug abusers, we have the right-sided valve to be more commonly involved as compared to the left-sided valve. And enterococci is important after GIT or GUT infection or procedures. So microorganisms consistent with infective endocarditis from persistently positive blood culture. So either we are going to take more than 2 blood cultures which are taken more than 12 hours apart. Suppose I take a blood culture at 8 a.m. and the next blood culture I am taking at 12 hours apart. and these two blood cultures are going to be positive. So the first is two blood cultures 12 hours apart. Now the second criteria is that more than 3 or most of more than equal to 4 separate blood cultures with the first and the last sample drawn more than equals to 1 hour apart. So that means suppose I am taking almost 4 blood cultures or at least more than that, and the first blood culture I have drawn at 8 a.m., then the last blood culture I should have drawn at 9 a.m. So this is the criteria, again, which is consistent with the major criteria of infective endocarditis. And the last one is actually a very important exam question, that where do you need in all cases of infective endocarditis, what I'm telling is that we need minimum of more than 2 blood cultures to be positive for infective endocarditis. So where do we require single positive blood culture? So single positive blood culture is required for an organism that is known as Coxiella burnetii, and you should also know about the titer, that is the IgG titer of more than 1 is to 800. So either it is a single positive blood culture or it is a IgG titer of more than equal to 1 is to 800, that is going to be positive for Coxiella burnetii. Okay, so in diagnosis of infective endocarditis, we find that blood culture plays a very, very important role, and we need to maintain the procedure of blood culture. So the one-liners which can be asked, what are the typical organisms that are involved in case of infective endocarditis, and where do we have, if we, for which organism a single positive blood culture is enough? The answer is Coxiella burnetii. And what should be the titer level? That is the IgG titer of more than 1 is to 800. Okay. Now coming to the echocardiographic evidence. Now, as I was telling in various cases previously, echocardiography is very important. So here also the second major criteria is echocardiographic evidence, which tells you about the endocardial involvement. Now, which echocardiography is better? So remember, it's a transthoracic echocardiography, which is better than transesophageal echocardiography. Sometimes in prosthetic valve or valve abscess, we prefer transesophageal echocardiography. But overall, if you're asked that for endocardial assessment in infective endocarditis, what is the investigation of choice? The answer will be echocardiography. And if more specific questions are asked, the answer will be transthoracic echocardiography. So what are the positive echocardiographic criteria for infective endocarditis? Number 1 is the oscillating intracardiac mass. Number 2 is the abscess, new partial dehiscence of prosthetic valve, and new valvular regurgitation. So we have these 4 criteria which are echo criteria of infective endocarditis. So remember, if you're asked that most common clinical manifestation of infective endocarditis, the answer will be murmur. So most common clinical manifestation of infective endocarditis will be murmur. So usually it's a new onset murmur, new valvular regurgitation. Okay. So if it is the most common symptom that you can get in infective endocarditis, the answer will be fever. And the second most sign or symptom in case of infective endocarditis will be splenomegaly. So other than this, we also find clubbing in the patient. Okay. And we have got minor criteria. In the minor criteria, we have got either there is a persistent fever or it is there are some risk factor which are positive, like IV drug abusers is there, or it can be some immune phenomenon or vascular phenomenon which are positive. And apart from that, some microorganism or microbiological criteria which is not matching to that of the major criteria. That is also possible. Okay. And we have got this immune criteria and vascular criteria which I'm telling about. We can have glomerulonephritis, osseous nodes, Roth spot, or rheumatoid factor falsely tested positive. Now what I would like to say, these osseous nodes are tender, whereas Janeway lesions are non-tender. So remember, osseous nodes are tender, whereas Janeway lesions are non-tender. And what spot do you find in the eye? We can get conjunctivitis, we get in the retina, we get rod spot. So rod spot is found in infective endocarditis and it is found in retina. Okay, and we can have falsely tested rheumatoid factor, which can be positive, right? And we can have other complications like mycotic aneurysms can be there, septic aneurysms can be there, etc. So remember, for infective endocarditis, we need to start on treatment, and treatment, of course, is on the basis of positive blood culture report, which organism we get, but we do not wait for the blood culture report. On clinical suspicion, if we have got a child with fever, splenomegaly, new onset murmur, clubbing, etc., we start on empirical antibiotics. And this empirical antibiotics, as per Nelson, we use gentamicin plus vancomycin, and the duration is for 6 weeks. Okay, so this is the treatment, empirical treatment that we give, and then we modulate our treatment on the basis of blood culture. If we get MSSA, that is methylene sensitive staph aureus, we usually add cloxacillin. If you're getting MRSA, then again we continue with vancomycin, right? And whatever organisms we get, we modulate the treatment according to the sensitive organism, and we start on the treatment based on the culture report. Now, sometimes we also give prophylaxis for infective endocarditis, cyanotic congenital heart diseases without any operative intervention, or partially repaired cyanotic congenital heart disease, right? Or in any diseases like, if you're going for bronchoscopy, endoscopy, where biopsy is taken, or some tooth procedures, dental procedures with a manipulation of the mucosa, right? Just dental flossing, you do not need to give prophylaxis. But suppose you are manipulating something in the mucosa, right, taking a biopsy, then you need to start on prophylaxis for infective endocarditis. So what is the prophylaxis? Rather, you should know what is the duration of prophylaxis that you provide. Prophylaxis is given for 6 months. So prophylaxis for 6 months. So antibiotic duration is for 6 weeks, whereas the prophylaxis duration is for 6 months. Okay. So clinical criteria of infective endocarditis, we need either 2 major criteria, or 1 major plus 3 minor or 5 minor criteria for diagnosis of infective endocarditis. Now coming to some one-liners from hypertension. Most common cause of hypertension in children, right? Remember, it is reno-parenchymal, which is more important than renovascular. Okay, so in all the cases, we need to go for ultrasound, KUB with Doppler, okay, because we need to see the changes in the kidney. Okay, the texture of the kidney, the corticomedullary differentiation, etc., and also about the blood vessels. Most common endocrine cause of hypertension, or the question can be put forward like this also: most common cause of hypertension in infancy, most common hormonal cause of hypertension in infancy. The answer will be 11 beta hydroxylase deficiency. So this is a type of congenital adrenal hyperplasia which presents with hypertension. Now, in hyperthyroidism also we can have hypertension. But remember, in hyperthyroidism, usually we have a normal diastolic blood pressure and increased systolic blood pressure. So there is an increased systolic blood pressure with normal diastolic blood pressure. Whereas in pheochromocytoma, which is nothing but a adrenal medullary tumor, whenever we go for an abdominal MRI, we find the light bulb sign. So light bulb sign in abdominal MRI is suggestive of pheochromocytoma, and pheochromocytoma will present with sustained hypertension or persistent hypertension. So what is the drug that we give in acute severe hypertension? So before telling this, let me tell you, there is a term called hypertensive crisis or acute severe hypertension. Now, hypertensive crisis can be divided into two types. Okay. Number one is the hypertensive emergency, and the another one is the hypertensive urgency. So remember, in hypertensive emergency, E for E, there is going to be end organ damage. So we can have some effect on the brain. There can be hypertensive encephalopathy or press. There can be effect on the heart, okay, heart failure, etc. So hypertensive emergency will present with end organ damage. So hypertensive emergency presents with end organ damage. Whereas hypertensive urgency is also a type of hypertensive crisis, but there is no end organ damage. So if end organ damage is present, it is hypertensive emergency, and if there is no end organ damage, it is hypertensive urgency. Okay, this is all about hypertensive crisis or acute severe hypertension. So what is the drug that we can give in acute severe hypertension? So we have three drugs. One is the labetalol. We can also give nicardipine. This is a calcium channel blocker. Also, we can give sodium nitroprusside. How to reduce blood pressure in hypertensive crisis? So usually the protocol is that we actually reduce 25% of the blood pressure in the first 8 hours, and then we gradually reduce the blood pressure in 24 to 48 hours. And there is no guideline of rapidly decreasing blood pressure, because if you rapidly decrease blood pressure, there is a chance of ischemia to the brain. Okay, so the target is reduction of 25% of blood pressure in the first 8 hours, and then we go slow. So what is the target reduction in blood pressure in case of children? So it is either less than 90th percentile for age according to the hypertension nomogram, or it is less than 130 by 80 in case of adolescents or older children. So the last is very, very important, that what is the markers of target end organ injury. So I'm telling that hypertensive emergency means that there is end organ injury, and end organ injury means involvement of heart, involvement of brain, involvement of kidney. We can have renal failure, we can have stroke, we can have hypertensive encephalopathy, we can have left ventricular hypertrophy, heart failure, etc. So what are the markers or laboratory markers, or what are the markers that we suggestive of target end organ injury? First is echocardiography, which is showing left ventricular hypertrophy. Number two is hypertensive retinopathy. One is the heart, next is the eye, that is the retina. Raised carotid intima media thickness, very, very important. Carotid intima media thickness. And the last is increased vascular stiffness. Increased vascular stiffness. Okay. So the last point you may not remember, but at least the points like involvement of the heart with left ventricular hypertrophy, hypertensive retinopathy, and increased carotid intima media thickness, these three are very, very important for your entrance point of view. Okay, so this finishes the one-liners which are expected from hypertension, right? And nowadays we also go for ambulatory blood pressure monitoring in order to identify white coat hypertension or masked hypertension. So next is a ECG waveform, and I would like you to see the anterolateral leads. Okay, see first in the one lead, can you appreciate the Q wave? Next, see the AVL. Again, the Q wave, which is very, very prominent, QRS. Okay, and next you see the anterolateral leads like the V3, V4, V5, V6. Okay, so in all this, there are deep Q waves. Okay, so deep Q waves in the anterolateral leads. So the finding is deep Q waves in anterolateral leads. And deep Q waves in anterolateral leads is suggestive of a condition where there is ischemia in children. So, in children, we do not get cases of myocardial infarction, but a congenital condition which leads to ischemia in children and can lead to myocardial infarction in children, that is nothing but ALCAPA. So what is ALCAPA? It is anomalous origin of left coronary artery from pulmonary artery. So let us expand the abbreviation of ALCAPA. It is anomalous origin of left coronary artery from pulmonary artery. Okay. So anomalous origin of left coronary artery from pulmonary artery is what we call as ALCAPA, and it is because of the deep Q waves in the anterolateral leads what we are going to get in the ECG, and we can go for echocardiography. We'll find an enlarged heart suggestive of dilated cardiomyopathy. Okay, so this is about ALCAPA, and you should remember that it is one of the most important causes of ischemia in children. Now, next we are going to do a syndromic condition. So, first let us look at the face. So, there are facial dysmorphism, and can you find out that there is a pointed chin with broad forehead? Okay, and this is known as a triangular facies. Okay, so this is a triangular facies that we are going to find. So, triangular facies or facial dysmorphism. Now, look at this. There is a vertebral involvement also, and the vertebra is shaped like a butterfly. Okay, so there is a involvement of vertebra also. So skeletal defect in the form of butterfly vertebra. And there is jaundice in the patient also. So there is a feature of cholestasis. And as you can see, there is a picture of eye. So there is eye manifestation also. And what is the most common eye manifestation here? There can be plenty eye manifestation like Exenfield anomaly, posterior embryotoxin. But the most common is posterior embryotoxin. So what is meant by posterior embryotoxin? It is basically deposition in the Swalby's line. Okay, so triangular facies, butterfly vertebra, cholestasis, posterior embryotoxin. So this is a syndromic condition. This is known as the Alagille syndrome, and very, very important. And Alagille syndrome is also going to present with cardiac involvement. So Alagille syndrome, why there is cholestasis in case of Alagille syndrome? Because there is paucity of bile ducts in Alagille syndrome. So paucity of bile ducts occurred in Alagille syndrome. So what is the most common cardiac lesion that we can find in Alagille syndrome? So most common cardiac finding is in Alagille syndrome, branched peripheral artery stenosis. So triangular facies, facial dysmorphism, vertebral defects, butterfly vertebra, along with jaundice, cholestasis with eye abnormalities, posterior embryotoxin, and cardiac findings, all this constitutes something which is known as Alagille syndrome. So let us read what are the genetic involvement in case of Alagille syndrome. Okay, so it is the JAGD1 gene on chromosome 20p12 and Notch2 gene on 1p12. So it is the JAGD1 and Notch2. And as I said, the most common cardiac lesion is peripheral pulmonary artery stenosis, followed by pulmonary valvular stenosis and TOF. So TOF is also associated with Alagille syndrome, but as I told you in my previous topic, that the most common syndromic association with TOF is DiGeorge syndrome. Okay. Now let me tell you another syndrome which is associated with with infantile cholestasis. That is known as the Agonis syndrome. So Agonis syndrome is again associated with cholestasis plus lymphedema. So cholestasis plus lymphedema constitutes the Agonis syndrome. Whereas already I told you about the Alagille syndrome. In Alagille syndrome, you need to remember what are the components of Alagille syndrome and what is the, even if you cannot remember the chromosome, at least the gene, that is the JACT1 and the NOTCH2 gene, and what is the most common cardiac lesion that we get in Alagille syndrome. So next we are going to read something which I was talking previously in much more detail, that is about the 22q11.2 microdeletion. And yes, you're right, we are dealing with nothing but DiGeorge syndrome. Okay, so we are going to read about the DiGeorge syndrome. So each and every line is important regarding this DiGeorge syndrome. First is chromosome, that is 22q11.2, and it is a micro deletion, again important, and it is because of haploinsufficiency of, so which transcription factor we are talking about? It is TBX1 transcription factor, and it's a velocardio-facial defect involving endodermal derivative of third and fourth pharyngeal arches. So it's an endodermal derivative of third and fourth pharyngeal arches. So what is the most common cardiac lesion that you get in case of DiGeorge syndrome? It is interrupted aortic arch, followed by truncus arteriosus, followed by TOF. I told you previously also that in TOF, the most common lesion that you get is DiGeorge syndrome. But in DiGeorge syndrome, the most common cardiac lesion is not TOF, but interrupted aortic arch. And we all know the mnemonic, that is catch-22. So let us expand what is catch-22. C for cardiac defect, A for abnormal facies, T for thymic aplasia, C for cleft palate, and last H for hypocalcemia. So congenital heart disease or a syndromic condition which is associated with a congenital heart disease and that presents with electrolyte abnormality of hypocalcemia, the answer is DiGeorge syndrome. So every word is important: cardiac defect, cleft palate, hypocalcemia, endodermal derivative of third and fourth pharyngeal arch, 22q11 microdeletion, and TBX1 transcription factor. So all are very, very important one-liners for your exams. And you can be given some image-based question also. You can be given these pictures and you can be asked that baby presented with cleft palate with facial dysmorphism and cardiac lesion. Along with that, chest X-ray reveals thymic aplasia. What is your diagnosis? The answer will be DiGeorge syndrome. Which chromosome is affected? Chromosome 22q11.2 microdeletion. Which arch is involved? Endodermal derivative of third and fourth pharyngeal arch. What electrolyte abnormality can we get here? Answer will be hypocalcemia. Now next, another syndromic condition associated with a heart disease where there is hypercalcemia. So we rate hypocalcemia in DiGeorge syndrome. Hypercalcemia is associated with this syndrome. So this is, first look at the faces of the child. Okay. So if I see the faces of the child, it is known as the Elfine faces. Elfine means ghost in Greek mythology. Okay. So this is the Elfine faces. The child will have hypertension and there is going to be cocktail personality. That is, the child will be over friendly with everybody. And what is the most common cardiac lesion that you get in Williams syndrome? Much repeated question. It is supravalvular aortic stenosis. If you do not get supravalvular aortic stenosis, the next best answer is peripheral pulmonary stenosis. Because once it was, there was one question, pulmonary stenosis is present in the following following conditions except, and there we had option of Williams syndrome, we had congenital rubella syndrome, and we also had Alagille syndrome. So all these three are correct, because in Alagille syndrome we have the branched pulmonary artery stenosis. As I told you, in Williams syndrome the most common lesion is supravalvular aortic stenosis. but we can get peripheral pulmonary stenosis, and definitely we are going to get it in congenital rubella syndrome. Another syndromic condition where you get pulmonary stenosis is Noonan syndrome. Okay, so hope you remember congenital rubella syndrome with pulmonary stenosis, Noonan syndrome with pulmonary stenosis, Williams syndrome with pulmonary stenosis, and Alagille syndrome with pulmonary stenosis. However, in the Alagille syndrome, if we have to specify, we'll say branched pulmonary artery stenosis as the most common cause. In the Williams syndrome, we'll say supravalvular aortic stenosis as the most common cause. In congenital rubella syndrome, it is the patent ductus arteriosus as the most common cause. However, the most common cardiac lesion in Noonan syndrome is definitely pulmonary stenosis. So since we are doing Noonan, let me tell you what is the most common in Turner syndrome. It is bicuspid aortic valve. So here it is involvement of elastin gene, and it is chromosome 7q11.23. You can remember just chromosome 7, and remember it's also a micro deletion. So this is nothing but the Williams syndrome. Okay, so this is about the Williams syndrome. So heart disease with hypocalcemia is DiGeorge syndrome. Heart disease with hypercalcemia is Williams syndrome. And DiGeorge is chromosome 22, Williams is chromosome 7. DiGeorge, it's a problem with the transcription factor TBX1. Here the gene involvement is elastin. In DiGeorge, we have the interrupted aortic arch and also trough. And in Williams, we have the aortic stenosis and pulmonary stenosis. Okay. So suppose you are given this type of picture and you are asked what is the most common cardiac lesion. You need to mark supravalvular aortic stenosis as the most common lesion that you get here. Now coming to another syndromic condition that is known as the Vacteral. So let us expand the term Vacteral. V for vertebral defect, A for anal defect, C for congenital heart disease or any cardiac defects, T for tracheoesophageal fistula, E for esophageal atresia, R for renal anomalies, and L for limb defect. So remember which syndrome is associated with tracheoesophageal fistula. The answer will be Vacteral syndrome, right? Now limb defect. So these two are very important. One is the tracheoesophageal fistula and number 2 is the limb defect. So can you tell me the most common type of tracheoesophageal fistula? The most common type of tracheoesophageal fistula is type C or type 3. Okay, that is the most common type. And on other conditions where we get limb defects, you can remember about the TAR syndrome. What is TAR syndrome? Again, much repeated. This is thrombocytopenia plus absent radius. Okay, and next we need to remember about the Hall-Torum syndrome, where you can also have some limb defects, and it is associated with atrial septal defect. And you need to remember one bone marrow failure syndrome, that is the Fanconi anemia. So Fanconi anemia is a triad of skeletal abnormalities, plus chromosomal instability, plus bone marrow failure. So skeletal abnormalities plus chromosomal instability plus bone marrow failure. So if I need to ask you this question, that what is the most common bone marrow failure syndrome, the answer will be Fanconi anemia. Again, if the question is like this, that it is the most common cause of pancytopenia with with acellular marrow, the answer will be again Fanconi anemia. So pancytopenia with acellular marrow, bone marrow failure syndrome, inherited bone marrow failure syndrome, the most common cause is Fanconi anemia. There is chromosomal instability in Fanconi anemia, and Fanconi anemia we can get limb defects. So Hall-Torum syndrome is ASD, and thrombocytopenia absent radius is TAR syndrome, and we already did about the Vacteral syndrome. Another thing I would like to say about one infection, one torch group of infection or one congenital infection which produces limb defects. The answer is varicella. So, varicella, you need to remember two things about congenital varicella. So, we have got cicatrizing lesions, that is the scarring lesions in the body. Along with that, we are going to get limb defects or limb hypoplasia. And a renal condition where we are going to get oligohydramnios, pulmonary hypoplasia, bilateral renal agenesis, as well as limb defects and facial dysmorphism. The answer is Potter syndrome. So Potter syndrome will also present with limb defects. So let us write down the components of Potter syndrome. I'll also tell it in my nephrology masterclass. So Potter syndrome is going to present with oligohydramnios, plus there is going to be pulmonary hypoplasia, plus there is going to be bilateral renal agenesis, and there is going to be limb defects. Lower limbs defects are more common than the upper limb defect, and definitely facial dysmorphism. So most common cause of death in Potter syndrome is basically because of pulmonary hyperplasia, and there is another condition where this pulmonary hypoplasia plays a very poor prognostic role, and it is also the most common cause of death in that condition also, that is congenital diaphragmatic hernia. So in congenital diaphragmatic hernia, the most important prognostic factor is pulmonary hypoplasia, and that is also the most common cause of death. So these are the conditions which I told is associated with limb defects. Okay, so we have the Vacteral, we had the Potter syndrome, we have the varicella, we have the thrombocytopenia absent radius syndrome, Holterum syndrome, and Fanconi anemia. Okay. Now we'll read some of the syndromes which are associated with heart disease. First is the Down syndrome or trisomy 21. So Down syndrome, the most common heart disease is endocardial cushion defect. ECD is endocardial cushion defect. So after endocardial cushion defect, if you're asked about the second most common heart disease in case of a child with Down syndrome, the answer will be ventricular septal defect. In trisomy 18 and trisomy 13, that is Edward Bada name, Bada chromosome, trisomy 18. Patau syndrome, trisomy 13. Both the cases, ventricular septal defect is more important. In Turner syndrome 45XO, I already told you that bicuspid aortic valve is the most common, followed by coarctation of aorta and aortic stenosis. So at least you should remember bicuspid aortic valve and coarctation of aorta. In CRY-DO chat, you need to remember this very, very important, that deletion 5P 15.2, at least deletion 5P, P भी याद रखना है. Deletion 5P is CRY-DO chat syndrome. The most commons being PDA, TOF, and septal defect. At least PDA is associated with deletion 5P. And Noonan syndrome, already I told you that it is associated with pulmonary stenosis. So Downs, endocardial cushion defect and VSD. Patau Edward is VSD. Turner's is bicuspid aortic valve and coarctation of aorta. CRY-DO chat, deletion 5P. Noonan syndrome, pulmonary stenosis. These are the bare minimum that you need to remember from cardiology and syndromes. Next, some maternal conditions and diseases. First is if the infant of diabetic mother, if the mother is having diabetes mellitus. Okay, so the most common cardiological finding that you can get is transient hypertrophic cardiomyopathy. So the maternal diabetes, if a child is having maternal diabetes mellitus, then the most common cardiological finding is transient HCM. If that is not given as the option, sometimes it is written asymmetric septal hypertrophy. It is written sometimes as asymmetric septal hypertrophy. If this is not given in your question, the next best answer is VSD. Remember, TGA is the most specific lesion in infant of diabetic mother, but it is not the most common. right? I actually gave you the entire order that you get in maternal diabetes mellitus. It's HCM followed by VSD followed by ASD followed by TOF followed by TGA, right? So there are 3 or 4 questions from infant of diabetic mother. The first is that you already know in infant of diabetic mother, if the infant of diabetic mother is having seizures, the first thing you need to do is to check blood glucose, right? Capillary blood glucose. If the capillary blood glucose is normal, then you need to check the electrolyte calcium, because hypocalcemia is again associated with seizures in infant of diabetic mother. Next, you need to remember that in diabetes, if the mother is having diabetes, there is a chance of congenital anomalies, and gross congenital anomalies are more common in overt diabetes mellitus as compared to infant of diabetic mother. That means if the mother is having a pre-gestational diabetes पहले से ही था, तो उसका chance of having gross congenital anomalies is much more than another one who is having diabetes during pregnancy. Understood? So in gross congenital anomalies, the most common organ involved is, or most common manifestation is, sacral agenesis, or what is known as caudal regression syndrome, right? And if I have to go for the CVS, then a most common CVS finding is going to be transient HCM or asymmetric septal hypertrophy. If the question is most common congenital heart disease found in maternal diabetes mellitus, the answer will be VSD, and the most specific disease found in maternal diabetes mellitus is going to be TGA, right? So I'll just mention it for you. As I said, in maternal diabetes mellitus, the gross congenital anomalies are more common in pre-gestational as compared to gestational diabetes mellitus. Okay, so most common CVS finding is HCM or asymmetric septal hypertrophy. However, the most common congenital heart disease is ventricular septal defect followed by atrial septal defect followed by TOF followed by TGA. Is the most specific congenital heart disease, the answer will be again TGA. And most specific lesion in diabetes mellitus overall is sacral agenesis or caudal regression syndrome. And I already told you in maternal diabetes mellitus, we should first look for blood glucose if the baby is having seizures. And if the blood glucose is normal, then we need to check calcium. So TG is also associated with maternal phenylketonuria. So maternal diabetes mellitus, most specific is TGA. Again, maternal phenylketonuria, it's again we can have TGA. I already told you if the mother is having SLE, we can have anti-Rho, anti-La antibodies to be positive. And we can have congenital heart blocks. And if we have the complete heart blocks, what is the fetal therapy of choice in case of maternal SLE? Then the answer is dexamethasone. Next, coming to the definition of pulmonary artery hypertension. So it is the mean pulmonary artery pressure is more than 20. So this only comes in the question. That is, the mean pulmonary artery pressure is more than 20 millimeter of mercury. Pulmonary artery wedge pressure less than 15 millimeters of mercury, and pulmonary venous resistance more than 3 Wood units meter square. So even if you cannot remember about the pulmonary artery wedge pressure being less than 15 or pulmonary venous resistance being more than 3 Wood units meter square, at least you need to remember about that mean pulmonary artery pressure is more than 20. And what is the most common cause of pulmonary artery hypertension? Again, it is the heart disease followed by chronic respiratory disease. And the viral infection which is associated with pulmonary artery hypertension, the answer will be HHV8. So HHV8 is associated with pulmonary artery hypertension. Remember, There are two cardiomyopathies which are associated with sudden cardiac death. One is hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy, and also ARVD. Okay. So that finishes our pediatric cardiology sector. In the next sector, we are going to do the pediatric endocrinology part. Thank you.